started. Welcome everybody. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Thank you all for coming this evening. Before we do get any further, I would like to acknowledge the traditional custodians of the lands we walk, reside and work upon. We pay our respects to First Nations people and value the continued connection to culture, country, waterways and contributions made to the life of our vast region. I'm coming to you from Ennewan land in the beautiful Northern Tablelands. We are using MS Teams webinar tonight. It's the first time I've used this platform, so please be patient if anything goes awry. Please put any questions that you have in the chat box. The last slide tonight will be a QR code that you can do the evaluation on. We really love getting your feedback, so please scan that and you can fill in the evaluation in Slido. Tonight's event is accredited, so I will upload your hour with RSCGP and or ACRM. Another reason that would be great to have your evaluation so that I know for sure that you're here and that you have listened very intently. All right, I'll just pass over to Professor Michelle Guppy. Thank you.
Thank you so much, Jenny, and welcome everybody. It's been really great to have such a huge interest in this topic. So I'm really excited that we've got a really fantastic panel of people to present to you tonight. So firstly, just to introduce everybody, Dr. Nick Boyd is a general practitioner at the Associate Medical Practice in Moree. Dr. Emily Gibson is an epidemiologist with Hunter New England's Population Health Unit. Dr. Mark Lowenthal is an infectious disease physician with Hunter New England LHD. We've got Professor David Durkheim, who's the Director of Health Protection at Hunter New England Population Health. We've got Ms. Sharon Saxby, who's an immunisation clinical lead, CNC, for Hunter New England, and she's been travelling around the region this week educating people about vaccination. So great that she can slot in some time here tonight. Dr. Hema Varadhan is the Director of Microbiology at New South Wales Health Pathology Hunter Region. Dr. Jackie Epps is a Senior Lecturer in Rural Medicine at the School of Rural Medicine. Professor Kim Usher is the Dean of Medicine and Health at UNE. And I think I forgot to introduce myself. I'm Michelle Guppy and I'm the head of the medical school and also a GP. So without any further ado, we will kick off. And firstly, Emily Gibson and Dave Durkheim are going to give us a little bit of information about the ecology and epidemiology of Japanese encephalitis. So I'll hand over to you. Thanks, Emily.
Thanks so much, Michelle. So if we could just move a couple of slides in. Thank you so much. So hi everyone, thanks for coming to the presentation this evening on Japanese encephalitis. This is once again a concern for us this mosquito season. My name is Emily, I'm the Zoonotics and Biopreparedness Epidemiologist at the Hunter New England Public Health Unit. I've got a special interest in flaviviruses, so I'm really pleased to be here to talk to you about what we know and what we don't yet know about the ecology and epidemiology of Japanese encephalitis, or JEV as I'll call it. So I'll start by giving you a little bit of background. JEV's a flavivirus. It's in the same serocomplex as dengue, Zika, West Nile virus and yellow fever, amongst others. The relatedness of the viruses within the serocomplex can make diagnosis quite difficult, and this is one of the reasons that the Zika outbreak went undetected for such a long period of time, and of course that greatly contributed to the severity. So JEV was first reported in Japan in 1871. It's an important cause of viral encephalitis throughout Asia and the Western Pacific. The incidence varies from country to country, but rough annual estimates of the disease burden are at approximately 100,000 clinical cases with an associated 25,000 deaths. In countries where JEV is endemic, it primarily affects children, as most adults will have immunity from childhood infection. However, individuals of any age may be affected, and that's what we're seeing in Australia, where JEV is much more recently emerged. And next slide, please. So this is the current global distribution of Japanese encephalitis, with countries in orange deemed to be at risk and areas in red are those from which we've had reports of JEV cases, and that includes the Victoria, New South Wales outbreak. JEV is thought to be spreading, like many mosquito-borne viruses, due in part to climate change and associated weather conditions. Next slide, please. So in Australia, JEV was initially confined to the northern parts of the country, with locally acquired cases reported in far north Queensland in 1995 and 1998, and that was caused by genotype G2 of known genotypes 1 to 5. In 2022, 3 Australian states reported JEV genotype 5 cases for the first time, marking a significant change in the epidemiology. Analysis suggests that this genotype had previously been restricted to Indonesia and Vietnam from 1980 onwards, and then spread to the Tiwi Islands, which are in the Northern Territory between 2005 and 2020, and then finally to Queensland between 2020 and 2022. It is likely that changes in La Niña and associated extreme weather events have pushed the virus to southern states, and that resulted in a communicable disease incident of national significance, or CDINS, being declared in relation to the human outbreak on the 4th of March in 2022. By the end of that outbreak, we had 45 human cases reported with 7 associated fatalities. 84 piggeries were also reportedly affected. Next slide, please. So the primary vector for JEV in Australia is a mosquito species known as Culex annulirostris. Other species may well be implicated, but we do need a bit more research here to determine. Likewise, water birds, specifically ID'd water birds such as herons and egrets, are considered to be the natural reservoir. The natural reservoir plays a crucial role in maintaining the virus and its geographical spread. Infection in the birds is generally asymptomatic. Also in the transmission cycle, we've got pigs. They are amplifying hosts and they do experience a clinical illness, and that includes reproductive disease and losses. This is often how we pick it up for the first time, stillbirths in pigs. Humans and horses are both what we call dead-end hosts, so they can't transmit the virus onwards. Both species experience an encephalitic illness with similar outcomes. Other vertebrate hosts may play a role, such as bats and young poultry, but again, we don't quite fully understand this yet. And next slide, please. So JEV is a notifiable condition right across Australia. It's an urgent condition, meaning that public health follow-up starts within 24 hours of notification to the relevant unit. The testing that we perform is serological or virological, and there's details on the slide there. The samples that we test are blood, urine, and CSF where it's appropriate. Notifications should be made to laboratories upon diagnosis, and by laboratories upon diagnosis, and that's ideally by telephone within an hour of confirmation. Patients that have a clinically compatible syndrome suggestive of JEV should be referred to hospitals for treatment. Next slide, please. So this slide demonstrates the infection dynamics of JEV to inform testing practice. Following the incubation period of 4 to 14 days, a viremia develops around 1 day before symptom onset. It peaks at about day 1 and then it declines until day 7. IgM can be detected from about day 4, peaks around day 9 and then declines until day 90. IgG is detected slightly later at day 5. It peaks around day 20 and it declines from that point on. By 6 months, JEV is no longer detectable in the serum of about 50% of patients, but may persist in the CSF. And next slide, please. So this is the Australian case numbers over time in an epicurve. Please note that it does include imported cases from overseas, of which we have had a few over the years. What it does show is the rapid increase in cases experienced in 2021 for New South Wales, Vic, Queensland and South Australia. New South Wales, as you can see from the navy blue line there, had the highest reported number of cases of the jurisdictions affected in that outbreak. Next slide, please. So this is the reported location of the Australian JEV cases. The small red dots are the 2021 and 2022 outbreak. And next slide, please. So in New South Wales, we had many LGAs affected and 2 deaths reported from Griffith and Federation LGAs. As many cases are asymptomatic, we know that these numbers are only the very tip of the iceberg, And so we did 2 serosurveys, one in New South Wales and one in Victoria, to try and ascertain the rate of infection and associated factors. Next slide, please. So the New South Wales serosurvey took a convenient sample from 5 regional towns at high risk: Bowranau, Corowa, Dubbo, Griffith and Temora. 917 participants were recruited, of which 80 were found to be seropositive for by JEV-specific total antibody, and that was 8.7% of the cohort. In terms of risk, participants over the age of 65 or older had higher seroprevalence, as did males, and 12% or 5 of the 42 Aboriginal and Torres Strait Islanders that were in the cohort were seropositive. Next slide, please. So the Victorian serosurvey covered 3 regional public health units deemed to be high-risk areas, and that was based on previously diagnosed cases. The survey opportunistically recruited 813 participants from the regions of Gippsland, Loddon Mallee and Ovens Murray. Of the 813 participants, 27 were found to be JEV IgG seropositive, or 3.3%, so lower in Victoria than New South Wales. And next slide, please. And so finally, this is the current season epidemiology, and we use a number of different surveillance types to monitor the situation, and that includes our sentinel chicken flocks, mosquito trapping and testing, and the opportunistic sampling of feral pigs. So far this season, there have been detections of JEV in mosquitoes in Griffith in early December and Moree in late December. There have also been detections in Victoria and the Moira Shire, which borders New South Wales. We have had detections of feral pigs in our region, specifically Narromine in mid-December, and more recently in Gwydir Shire. We've had no seroconversion noted in the sentinel chickens for JEV, though one chicken has seroconverted for Murray Valley encephalitis, and that was in the West Wyalong flock. We've had one confirmed human JEV case in Victoria who may have had a New South Wales exposure and has experienced quite a significant clinical illness and is, as far as I know, still in ICU in Melbourne. So we've also had a human case reported in Queensland in January, and that marks the state's first detection since 2022. That case was reported to have acquired his infection whilst on a camping trip in Goondiwindi in southern Queensland, where we have had detections from mosquito trapping and testing there. So taken all together, this indicates that JEV may be quite widespread in regional New South Wales and other parts of the country this season. So I'll now hand over to Mark Lowenthal, who's our Director for Immunology and Infectious Diseases. Thanks very much for your time, and thanks, Mark.
With a headache and with a healthy conscious state, the things you want to think of first are: has this person got meningitis? So meningitis is fever, neck stiffness, headache, fever, neck stiffness, photophobia. Have they got encephalitis, involvement of the brain, which is seizures, altered conscious state, or focal neurological signs? And that can actually include behavioural changes as well. Because if they have meningitis, you want to know whether you're thinking, am I going to give this person treatment for meningitis, including treatment for bacterial meningitis? That's a life and death thing. And if they've got encephalitis, I'm actually thinking, okay, am I going to give this person treatment for herpes encephalitis? Because again, that's a treatable condition. And so that's important. So clearly, these patients all had short prodrome and features of encephalitis. In this case, it was clearly an outbreak. But the other thing is, in the flavivirus infections, we often get a peripheral neutrophilia, and that is also the case with ordinary intraviral meningitis, which is sort of a complex cause of asymptomatic aseptic meningitis. So people have the idea, a lot of people have the idea, neutrophils, bacteria, but in fact, neutrophilia is the norm in Murray Valley encephalitis, Japanese encephalitis, and in fact, in aseptic meningitis, in ordinary aseptic meningitis that we get here from enterovirus. And similarly, particularly if you do a lumbar puncture early, there's a neutrophil or polymorphonuclear predominance to start with. So Japanese encephalitis, rapid onset encephalitic features, don't be put off by neutrophilia. And no rash, no lymphadenopathy, normal chest X-ray, normal CSF glucose, which is important in distinguishing it from bacterial meningitis. If we just quickly go to the next slide, I'll give you the end of the story and pass it on to the next person, because when we come to the clinical case, we can look at the other things that they could be, the zoonoses, how you go about diagnosing them, and how both on history examination and on basic investigations that are going to be available to you within a day or so in Moree. So that was Japanese encephalitis, but public health unit went up there. They sort of got the people of Vanuatu Island on their side. They actually cultured the blood of quite a few people, and we grew Japanese encephalitis from 2 asymptomatic people. And once we did that, that absolutely confirmed the diagnosis. Of course, by then it was actually sometime later, but we were on that clinical presentation. We were really working on the diagnosis of flavivirus encephalitis. And the other thing that the 16-year-old and the 44-year-old, they actually died, and they actually had basal ganglia infarction that was visible on a 1995 CT scan. And that's also a feature of Murray Valley and Japanese encephalitis. So there was actually an epidemic in the Torres Strait at that time. Most people are completely asymptomatic, but the people who are symptomatic have a significant case fatality rate, and it's a serious illness that comes on really quickly. I'll talk to you again during the discussion.
Thank you very much for that, Mark. And now we're going to move on to a discussion around vaccination. So welcome, Sharon.
Thank you, Michelle. Next slide, please. We'll talk about protection. So I think we're all very familiar with the funded vaccination and who is eligible to receive this vaccine within New South Wales Health. So it's for all people from 2 months age and older who live or routinely work in any of the LGAs of high concern, of which we know there are many. And I think this first criteria here, who regularly spend time outdoors, is probably the most significant, because being summer, most people are outdoors most of the time. And we also have people living in conditions with limited mosquito protection, or engaging in outdoor flood recovery, including professional and volunteer deployments. So thank you, Michelle. There are plenty of LGAs of high concern, and most of these, if you look at the map, exist, next please, west of the Great Divide, except for Little Upper Hunter area, which is very close to the Great Divide, but you can see it's an enormous part of New South Wales and an awful lot of Hunter, New England. So we should all be very concerned that we live in one of these LGAs. Thank you, Michelle. So vaccines have been distributed for quite some time now, and we can see in the orange bars is GPs, and we can see that they have been ordering the most vaccine more than anybody else, closely followed by pharmacies. And we can see that big spike towards the end of last year and beginning of this year. And I will have to say that Moree, there's some very proactive people, especially a proactive medical facility up in Moree, who I had a lovely chat with the nurse there, and they're being extremely proactive with their patients in asking if anyone would like a vaccine and advertising. Next, please, Michelle. There's 2 more bits. So we can see there that in Hunter, New England, over the last 30 days, there's only been, seems like a lot, but 2,200 vaccines distributed. But if you look down the bottom right, that only constitutes about 440 orders. So most of those orders are actually really small amounts, and they're in response to a couple of people coming in and asking for the vaccine. So places that providers are just ordering a few vaccines. Really like to encourage people to order bulk amounts and actually be proactively speaking to people about vaccination and having the vaccine available when they come in. So next, please. A lot of vaccine going out, but how much is actually getting into arms? So a little bit of a different story here. Once again, we see that spike towards the end of last year and beginning of this year. Next, thanks, Michelle. But we can see if we really look here, these are the top Hunter, New England LGAs of the vaccines administered via air. We can see that there's like Narrabri has 731 vaccines that they've actually administered. Sounds like a significant amount, but when you look at the vaccination per 1,000 population, it is not very many. It's only 56 people per 1,000. So we have a lot of work to do. These are areas of really high concern, and we know especially up around Moree, that's looking at only 35 people per 1,000 of population has been received a vaccine so far. We know there are some discrepancies with air reporting, but there's a lot of work to do, and I think we can all encourage our clients' population to be vaccinated. So I'd like to encourage you there. Next, thank you. So what vaccines are we going to use? 2 vaccines available. So there's Imagev, which is a live attenuated vaccine, and this is for people 9 months of age and older. It's a single dose of 0.5 of a ml, and it's by subcutaneous injection. We need to remember with a live vaccine, we need to really be careful that they haven't been given a live vaccine in the previous month. So live vaccines, if not given on the same day, need to be separated by 28 days. So checking air and patient record is really, really important if we want that vaccine to be effective. The other vaccine is Jespect. So this one's an inactivated vaccine. This is for people 2 months of age and older, and there's 2 dosing schedules. So from 2 months to less than 3, it's half a dose of 0.25 of a ml, 2 doses, 28 days apart. For 3 years and older, it's 0.5 of a ml, 2 doses, 28 days apart as well, and it's by intramuscular injection. Most people will be receiving and offered Imagev. There's an abundant supply of Imagev down at the vaccine centre, so please order lots of Imagev. Jespect is a vaccine that's in more short supply, and it is for people who can't receive Imagev. So Imagev is your first option. Next slide, please. Thanks, Michelle. Contraindications and precautions. So obviously anaphylaxis to any previous dose of JE vaccine or any component of a JE vaccine is a contraindication absolutely for receiving this vaccine. Imagev, being a live vaccine, is also contraindicated in anyone who's immunocompromised and in pregnant women. And if you are vaccinating women of childbearing age with Imagev, you need to let them know to avoid pregnancy for 28 days after vaccination. And breastfeeding women, there's not enough studies to know whether the virus from the live vaccine is actually excreted in breast milk. So breastfeeding women should not be receiving Imagev. So we know our precautions. We always have to be careful with our immunocompromised people. Here we would be prescribing Jespect as an inactivated vaccine. It's not expected to cause any safety concerns. However, there's few data on safety and efficacy. And as always, these people may not mount an adequate immune response. So we still need to be really selling mosquito virus protection, bite protection, etc. for these people. Pregnant and breastfeeding women, it's not usually recommended to receive this vaccine. But when they're at risk of acquiring JE, Jespect is the vaccine that we're going to use for these people. We do know that JE virus infection is associated with a risk of miscarriage in the first and second trimester. So vaccination is important for these people at risk. No adverse outcomes of pregnancy has been attributed to Jespect, and no specific data is available for using Jespect in breastfeeding women. So go forth and vaccinate. We expect to see a lot more vaccines being ordered and given. Thank you very much.
Thanks for that update, Sharon, and that's been really helpful for me just to also understand the different availabilities of each of those vaccines as well. So thank you for that. So look, now we're moving to our case discussion. And it'd be great if all our panel members can turn their cameras on and get ready to jump in and help us discuss this case. Those of you who are watching, if you've got any questions that are raised either from the presentations that we've heard so far, or if you have any questions that come up as we discuss the case, just pop them in the chat and then we'll have time to be answering those questions at the end of the webinar. So this is Greg Smith, and Greg lives in Moree. He's a surveyor and he's 42. He presents to the emergency department at Moree Hospital, having experienced 3 days of fevers with night sweats and rigors, and he's got a low-grade headache. He's also been feeling nauseated with some diarrhea. And over the past 24 hours, the headache has worsened and doesn't improve with simple analgesia. He feels more unwell with significant generalised weakness and fatigue. So he's triaged by the triage nurse, and his vital signs are a temperature of 39, a blood pressure of 110 on 70, pulse rate of 100, and a respiratory rate of 18. He's seen by the JMO, now that we have JMOs in Moree, and the JMO examines him and reports a clear chest, soft abdomen that's slightly tended to palpation, and a normal urine dipstick. He's oriented, but he's vague, and he's easily distracted with some simple questions needing to be repeated. He's very fatigued. There's no neck stiffness or other signs of meningism, and a COVID rapid antigen test is negative. The JMO takes a further history, and Greg works outside most of the time and travels around the region. He does wear long sleeves and long trousers because he's sun safe. He also lives just out of town on a small property where he runs 20 head of cattle. He enjoys fishing on his days off and spends a lot of time along the Guida River, which runs through his property. So JMO calls Dr. Nick Boyd and says, "Dr. Boyd, what should I do next?"
Yes, hello, thank you. Well, it's a not particularly specific history. It could almost be practically any viral illness. But one other thing I would be thinking about is that we have a lot of Q fever around our area, and also I'd like to explore that further and say, do you go pigging? Because that's a big risk factor for brucellosis in our area. So one thing that does concern me is this the history of him being vague and easily distractible, which in the context of this presentation makes you start to think of possibly an encephalitic presentation. I would be inclined to do basic biochemistry, including a CRP, a full blood count, do a blood culture with that high fever. With luck, we'd have, well, if it was bacteremic, I'd be hoping for a positive yield from that. And also, I know he had a negative COVID test. I would also do recommend a nasal swab for respiratory pathogens, PCR. I read or heard that's up to a third of the COVID antigens are falsely negative. Is that right? But I have yet to demonstrate a positive COVID after a negative COVID rat. And another thing, I think he's got the loose stool as well. I would also suggest sending off the stool too, and then we would review those results and probably give him some paracetamol if he's not had any recently, and see if he improves a bit just by bringing his temperature down. All right.
Thanks, Nick.
Okay.
And what's the time period do you think where you're likely to expect those test results back from Moree?
We could probably get them back in less than an hour, I would have thought.
Okay. Yep.
Well, not the PCR or the stool, but the basic pathology for blood count and CRP and biochemistry. Yes.
Yeah. Okay. Great. So it sounds like you're. Sorry. Go again.
I'm sorry. I want to carry on.
Yeah. So it sounds like you're considering a zoonotic infection, and so you give the on-call ID physician a call for some further advice, and Dr. Mark Lowenthal takes the call.
Yeah. Right.
Hi, Nick.
Hi there.
So I've heard this story, and I totally agree with everything you said. The thing that's most concerning is the fact that he's really not right. I mean, he's worked as a surveyor, and here he is. He's sort of distractible, confused. That's definitely is not unconscious, but he's already got encephalitic features there, hasn't he? That make us concerned. If he didn't have that, if he was completely alert and oriented, we actually wouldn't even put Japanese encephalitis at all in the differential diagnosis. Because so the fact that he's got, I think it's actually pretty abnormal for somebody in that age group. That's very concerning. And also, you do want to make a diagnosis, and in this particular case, considering this topic is Japanese encephalitis, I don't think there'll be a prize for guessing that. But in this, you're really concerned that they might have an encephalitis, and so the other things I go through. Sure, Q fever. He's got the exposure. He's got the chemical on his property. So, and Q fever is actually very contagious from animals to humans. That's a consideration. They may well have a bad headache, but very, very rarely have actual confusion. And so, I guess the first thing you're going to think is, if he has encephalitis, the one easily treatable form of encephalitis is herpes virus encephalitis. So that's going to be no differential diagnosis, and we're actually going to seriously consider giving him intravenous acyclovir in that situation. Can I quickly say for the other zoonoses, yes, if he's got the history of pig hunting, that's brucellosis. They're just generally sick, and you're going to make sure to write that on the request form, because the laboratory will definitely like to know that, and they'll help you with the diagnosis. But that does have a significant risk of laboratory infection. Really, the only people in Australia who get brucellosis are people who are in some way associated with pigs or pig hunting, and it's the people who butcher the pigs, because if you just shoot the pigs and leave them, you don't get exposed there, and who eat the pig meat, and who, which is why we are a net exporter of brucellosis. The other things listed there in our differential, the other zoonoses, leptospirosis. Look, virtually everyone with leptospirosis has a thrombocytopenia. Out of all the things in differential diagnosis, leptospirosis is the only one that gives you an abnormal urine. It'll give you an abnormal urinary dipstick. All the other things shouldn't do that. And they quite often have leptospirosis. Quite often have lymphadenopathy. I've never seen the pulmonary hemorrhage of leptospirosis in our region. That's something strain specific. We used to certainly get that in cans. So if you have on the ordinary blood tests, thrombocytopenia is leptospirosis. Don't let neutrophilia scare you off a viral diagnosis. They can, and Japanese encephalitis definitely has a peripheral neutrophilia. Q fever, there's nothing much on the full blood count, but typically there's abnormal liver enzymes. The only thing else we put in that list was Hendrovirus, which is anyone there that I've actually never seen, but it starts primarily as a respiratory infection. It's the main hosts are actually flying foxes, but humans typically have caught it from horses with respiratory disease. and it's people who deal with horses who catch it. You can get encephalitis from it. That's typically a late complication, even up to a year or more afterwards. It's not so acute. So Henry will I think we'll tell you in a minute about the diagnosis of Jay, but I agree with all of your investigations. And once we're thinking about Japanese encephalitis, we're going to take serology as well. And
yes.
If you end up doing a lumbar puncture, you're going to send that off for herpes virus PCR, as well as for all the usual things, and you will send some off for Japanese encephalitis as well, and you'll do an acute serology. But the big decision to make now is, have they got bacterial meningitis? They probably don't. Have they got herpes encephalitis, which they could have, because that's something that's treatable on the spot.
So thanks for that, Mark. And so Nick, just that question I have, I guess, is how easy is it to get a lumbar puncture done in Moree?
I think I last did one just over 18 months ago, but that was in the context of a spinal anaesthetic for a cesarean section, so I could do one, but I haven't done one for a while, And also I'm thinking that if they were an encephalitic picture, I would also, because we have GPs with visiting rights at Moree hospitals, I'd also be thinking about, I should be discussing this with maybe Tamworth or even John Hunter. Is this a person that's more suited, best managed by being transferred out? Yeah.
Definitely. And look, if you've got acyclovir there, you can start it, speak to them, and they can be transferred out.
Yeah.
They can have scans and other punctures later. You give them treatment. If you thought they had bacterial meningitis, same thing. You give them the antibiotics for that as well, and then think about scanning and whatever at a different setup.
All right. So can confirm he doesn't go pig hunting, and he's also not been vaccinated for Q fever, I wrote this case before discussing with Dr. Lowenthal. So Mr. Smith's admitted to Moree Hospital, and all those considerations around doing a lumbar puncture are made. He started on empirical therapy with doxycycline 100 BD and supportive therapy, and the blood samples, as per Dr. Lawrence's discussion, are taken for PCR and serology. So over the next few days, he continues to have fevers and headaches, but doesn't get any worse in terms of his encephalitic picture. And by the third day, he's starting to improve. His blood tests come back, and I'll hand over to Hema to discuss those results with us.
All right, thanks, Michelle. So first comes first, the routine blood. So we see some neutrophilia as discussed, and normal liver enzymes at this stage, normal CRP. So there's nothing really flagging there. Next slide, please. So the blood cultures have been negative at 48 hours. Patient was not on any particular antibiotics before collection. So if there is a true pathogen, we would have expected that to grow within that time. So as discussed, leptospira was one of the differentials. So we have done a serology for it, and the IgM antibodies are negative. And usually by the time patient develop symptoms, if it's true leptospirosis, we do see some small increase in IgM antibodies. So in this particular case, we haven't seen one, but that doesn't completely exclude. And let's say before we even go to Japanese encephalitis virus, let's imagine that the patient had a lumbar puncture, which would be the normal course of action for any encephalitis. We will do a multiplex PCR, which includes nearly 13 to 14 pathogens at this stage, including HSV. JEV is not included in that. And let's say it was negative for all pathogens, right? So we do see some slight increase in white cells. So CSF is pleomorphic, and therefore we suggest that a second-line testing, considering where the patient lives, we suggest a Japanese encephalitis PCR. So we do a PCR. Again, it comes back negative. So PCR can be done as mentioned by Emily, can be done on CSF, blood, or urine. The only problem with PCRs is that the viremic stage is very short-lived. So as soon as the virus infects the body, patient develops symptoms, we start developing what we call as neutralizing antibodies. The neutralizing antibodies try and fight the virus quite heavily. The viremic stage as such is really short, and therefore negative PCRs can occur during the course of illness, and that doesn't completely exclude JEV. Now, we also do a serology. So remembering that this first sample was taken at a very acute stage, less than 7 days into his illness. So we are likely to see some very low level or negative antibodies. So this is the serology result that we have. So generally speaking, when we are investigating for any flavivirus type infection, we look at the common flaviviruses that are circulating in our community and test for all those. The reason being the antibodies against these flaviviruses can be very cross-reactive as well as species specific. So we need to be able to also do testing for other cross-reacting flaviviruses, just to ensure that there's no cross-reacting antibodies, and also to provide a clue as to what could be the real reason. Now, the most important thing for us in terms of requesting is to say or mention in the request form as to whether the patient has traveled, because the epidemiology of flaviviruses is different in different countries. We have Japanese encephalitis, Kunjun, and Marivali circulating, and they all belong to 1-0 complex, and therefore cross-reactivity is very likely. But if you go to Asia or Southeast Asian countries like India, you have dengue and West Nile encephalitis co-circulating. So we need to understand which other viruses are co-circulating and what the potential for cross-reactivity is. And therefore, history of travel is quite important. History of vaccination is important, particularly with number of people getting slowly vaccinated. I would like to know whether this gentleman, 40-year-old gentleman, had received any vaccination, because that could give rise to some antibodies that we shouldn't be confusing with an acute infection, and antibodies due to infection. So those are the critical histories that we would expect on a request form and should be useful for interpretation. So in this particular case, as you can see, we have done the IgM and total antibody, which includes both IgG and IgM. The IgM for most viruses are, of course, when I say most, JEV, Kunjun, and Marivali were negative, but you see some slight, very low titers, around 10 for JEV, 20 for Kunjun, and as well as for Marivali, detected for total antibodies. Now, we are not sure, this is day 5 of illness. We are not sure whether it is due to the current illness or whether there's been a past exposure, and whether there is a slight boost in the antibody levels seen during an intercurrent viral, some other viral illness. So at this stage, we would suggest that we can't confirm that this is due to JEV or any flaviviruses of that group, and we would advise convalescent sample taken after 10 to 14 days.
All right, thank you for that, Hema. So on day 6, Mr. Smith feels much better and returns home, and he attends the pathology lab to repeat his blood tests 7 days later, and then makes an appointment with Dr. Boyd to see his results. His symptoms have resolved by the follow-up appointment. And these are his pathology tests after 7 days. Hema, would you like to comment on those for us?
Thank you, Michelle. So as you can see, the FBC has returned to some normal levels. There's nothing much in his biochemistry. Now we have a leptospira IgM that was repeated again after 10 days or after 7 days, which stays negative. We should have expected to see some positivity there if it was truly a leptospira. JEV, again, the flaviviruses group serology was repeated. I have put here the paired sera results, the one taken on 15th and 7 days apart, the 22nd. The one on the 15th, which I showed earlier, had very low level titers to all the viruses, the related viruses. And on the 22nd, you can see in the red circles, there has been a slight increase, what we call as a very low level fourfold increase in antibody titers to all the related viruses, JEV, Kunjun, and Murray Valley. Again, this is very problematic because it doesn't give us a clue to the species. It only tells us that there's been a general boost in flavivirus antibodies, and it doesn't tell us whether it is due to any particular viruses in that group. So at this stage, it's still inconclusive, and we can't reliably say that it is a Japanese encephalitis virus. However, this is not an unusual finding, particularly with flaviviruses when cross-reactive antibodies are quite prevalent. Now, typically at this stage, that advice from the laboratory would be to do what we call as a neutralization test. So the neutralization antibody test is the gold standard for diagnosis of particularly the JEV. So what we do is we have standard cultures of viral particles, the JEV particles. We add patient sera and the controls, and we look for the development of plaques and also see whether the addition of the serum sample from the patient is able to neutralize those plaques. So if it is able to neutralize, it means that there's neutralizing antibodies present, and the neutralizing antibodies are usually species specific, and that gives you a final a gold standard diagnosis. But let's say in this particular case, we haven't done that. So this is where we stand. Some increase in antibodies, but we are not quite sure whether it is typically due to JEV.
Thank you, Hema. So Mr. Smith asks Dr. Boyd, can I get this virus again, or am I now immune?
Oh. Well, given those results, I'm not quite sure what virus he's had, but I think it's possibly a flavivirus because they've all gone up fourfold, as Hema said. Yeah.
And so, Hema, at what point would you do those tests that you were describing?
Look, typically we will wait for at least 14 days because I don't want to be wasting testing on, it's still day 7 at this stage. So I would wait for at least 14 days, 2 weeks. One good thing is he's markedly improved, I guess. And this is, I don't say it's unusual, but people with encephalitis usually go slightly longer with their symptoms and in the infection. So it convinces me that it's probably not a very severe flavivirus infection that we're thinking about. But in any case, we would advise repeating serum at 2 weeks.
Okay, thank you. Dr. Boyd, can my wife catch this too? And should she get the vaccination? She's 14 weeks pregnant with our 3rd child.
Well, yes. Well, she is living in the same area as he is, so she'll have pretty much the same environmental exposures. So if we are thinking that it is Japanese encephalitis, she would be at relatively high risk as well. And I would suggest that she could have the J-spect as she is pregnant, and then repeat that in 4 weeks' time. Yeah. And that would, because that's a not a live virus, that would be safe during pregnancy. I would also recommend that he's got two other surveyors who work in the area. I would suggest that, assuming they are well, not about to become pregnant, or pregnant and not immunosuppressed, I would recommend they have the Imajev vaccine as well. And that's how I do it. We have been vaccinating quite a lot at the Associate Medical Practice. So far this year, we've managed to give 274, and there are another 54 booked in over the next 2 weeks. And 32 of those will be those coming up will be council staff as well. However, I know one thing we have fallen back on. We've only managed about 7 as identified patients as Indigenous who've had either of the 2 vaccine, which represents about 2.5% of the total vaccines given. And but when our Indigenous patient proportion runs at about 17%, of active patients.
Look, thank you for that.
And they should get that.
You got a round of applause from Sharon Saxby for those great vaccination rates, and it sounds like your practice is really very on board with promoting this to patients in the region.
Yeah, thank you.
I'm opening the floor to questions in a minute. If anyone, great that people are putting questions in the chat. I just want to go to Jackie Epps now and just see, are there any areas that you're interested in terms of research around this?
Thanks very much, Michelle. And please feel free to keep typing your questions and great answers in the chat while I'm talking, because I'm aware of the time. So JE is a classic zoonotic infection, and it does benefit from a One Health approach in terms of understanding the disease and the management of JE more broadly, and also One Health approach to research. And by a One Health approach, we mean there are human factors, animal factors, as well as the importance of the changing climate and ecology, as we've heard. The University of New England's got a heavy emphasis on One Health research, with expertise in agriculture, zoology, ecology, health and medicine, just to name a few. And the UNE is very keen to lead research projects on GEV. And with such a fantastic panel here tonight and collectively such broad knowledge, in a minute I'd like to ask the panel where you feel the key research priorities are. Some of that will be obviously connected to community studies and primary care, and we're going to hear of an example of this shortly from distinguished Professor Kim Usher from UNE. But also, are there any research priorities from a broader One Health perspective? So maybe while the panel's thinking on that, perhaps Kim, would you like to outline the plans for the new JEV study that the UNE hopes to be undertaking? I think we have Kim online. Can you hear us, Kim?
Yeah, thank you. I'm very happy. Thank you to be online. And yeah, as Jackie said, we're very keen to do some research in this. It's not my area of expertise, but I'm really happy to support Jackie in this because it's her area, and I'm just trying to support her. So some of the things we think we could do in the next few months, we hope, is to look at community understanding and community attitudes towards vaccination, community understanding or knowledge about JBE, and also looking forward to the future, whether there's a possibility to do a sero-prevalence study in our area that we know that there's been animals detected with JBE. So I think they're very important things. We've just got to find, obviously, get some funding to do this sort of stuff, but it's very important, and I really support Jackie going forward with this, and that's my role. It's not my area of expertise, but I'm prepared to help support her, and very keen to work with everyone across this discipline who wants to do this and research it in the future, because it's very important. We need to get on top of it now, and I would ask that anybody in the team today, the people who've come today to this meeting, if you're interested, just please join in with us and let us know if you're interested, because we want lots of participants. We want other researchers who want to be involved, And we also need collaborators who will be prepared to give out surveys in their local areas so we can collect data and make some sort of contribution to understanding what's going on in our local areas. So thank you. Thanks, Jackie.
Thanks, Kim. Thanks very much. And the panel, any other research area or priorities that you see that might be for at this particular point in time for GE?
Well, looking at our immunisation figures, I see that we have quite an underrepresentation of the Indigenous people with vaccination rates. I was wondering how best we could improve that. And also, as I mentioned earlier in this, I think it's in the Victorian or the southern New South Wales sero surveys, they found that if you were Indigenous, you were much more likely to be seropositive than say, a Caucasian person. So they are at increased risk going by that.
I'm interested in, I think, in vaccine uptake as well. How that can be influenced.
Yeah,
So,
excellent.
Yeah.
Excellent. Michelle, I might hand back to you, and people perhaps can type further things or get in touch after this if they have any more
Thank you so much,
ideas.
Jackie. Thank you, Jackie. Yeah, look, there's lots of great questions in the chat, and I think a lot of them have already been answered. I'm just scrolling through to make sure that there are some that haven't been answered. There's a question around if people don't have a GP, where can they access vaccination? Sharon, are you able to answer that at all? It sounds like from pharmacies.
Yeah, there's a lot of pharmacies ordering the vaccine. They're very keen to provide this for, so just go in and phone ahead or call in.
Okay, so that's a great message that we can get out to our region about that. There was a question around how effective the vaccine is, and which I think's been answered. It's highly effective in preventing clinical illness, and so thank you for that, David. Is there any evidence that it offers protection against other flaviviruses? And it sounds like it doesn't. And people in the Lower Hunter and Newcastle entitled to the free vaccine? It sounds like at this stage they're not. Is that that's right? Again, Sharon?
That's correct, yep.
Yeah, so they're not in an LGA of concern.
But if sorry. If they actually travel to some of those LGAs of high concern frequently and work, absolutely.
Yep. Okay. I'll just take a couple of final questions because we're running out of time. Anyone else have any outstanding questions that we've not answered yet for you? We will make this slide deck available to all our participants here tonight, so you'll be able to access the information that we've had on the screen so far. Just, I guess, a couple of final points. Health Pathways does have some updated information about Japanese encephalitis on it. And it also has information about the JV immunisation. So that's a really fantastic resource for you guys to access. If you haven't logged on to Health Pathways before or recently, it's now moved to a sign-on. You need to make yourself an account. It's pretty easy to do, and those are the instructions there. And again, these slides will be made available. So look, I really want to thank our panel tonight. I think you guys have been amazing. I've learned so much in an hour. It's been great in hearing just about how this virus is spread throughout Australia, the things we need to look out for as clinicians, the really fantastic message that there is a vaccine that is available for us to prevent this in our population. Some interesting areas of research where I think we do need to try and improve vaccination rates amongst those particular groups of people. So we'll take that on board. But thank you so much, everybody. Thank you to everyone on our panel. Really appreciate your input and your time for this. It's been good, and thank you for everybody who's come. I might just quickly hand up back to Jenny to see if there's anything you want to say, but this is, we'd love your feedback. If you could just click on this QR code and give us some feedback, that would be great. Thanks, Jenny.
Thanks, everybody. Fantastic presentation tonight. Lovely, all the questions coming in. I don't think I need to say anything else. So thank you for everyone, for the presenters giving up their time, for